Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back, everybody. It's the chance now to thank the chairperson and the Saudi Heart for giving us the chance to meet, and this is our fourth time to exchange the experience together. We just heard today about the corona thing. I think one of the treatment, that's the new treatment of diabetes, it's the camel milk, believe it or not. By analysis, they found that it has like a pro-insulin that could be given orally, and it could be used for treatment of diabetes. So maybe this is the best solution for cardiologists to treat their diabetic patients. Okay. As you can see now, that diabetes will really increase the risk of cardiovascular events, and it will increase the myocardial infarction or stroke in patients, especially when it is combined with other metabolic disorders. Thank you. I'm short, that's why. Thank you. Yeah, go ahead. As you can see now, diabetes has some facts that we all know. I know you are a cardiologist and you went through diabetes before. Just a little refreshment. We know that it's 4 types, and it's the 5th leading death cause in the world now. 41 million people are in the stage of developing diabetes in the US, and the progression takes a very short time. That's why we have to stop the complications. It costs a lot of money, $132 billion. This is just in the US. Imagine what's in the Gulf countries or in Saudi Arabia. It has an acute complications with chronic complications. The most complicated one, and the one that we're concerned about, is the macrovascular and the microvascular, because this is where we're trying to prevent this from happening. There is some data in Saudi Arabia that diabetes is almost up to 24-25%, and this is not an easy number. That means out of 4 Saudis, 1 is diabetic. In our heart registry, we found about 40% of our coronary artery patients were diabetic patients. And this is not all. We found that we cannot even do anything, even with therapy. We believe that preventing diabetes is an issue, but what if we couldn't do it and we couldn't give pills for prevention? I know that you're maybe specialized in cardiology, but there is some pills that we can use for the prevention, which is not the field now. Now we're talking about how to treat. What about heart failure? It is an issue. It has been classified, and I'm sure that you know the classification. And the most important challenge in heart failure is actually the awareness, the health awareness, and the hospitalization. That's the most major problem. The rehospitalization is an issue, and it has been even documented by our registry that within at least 1 year, we have 25% almost of our patients, they have at least 1 admission per year. So you can see now, diabetes by itself is a problem. Heart failure is a problem. What about if we have both in one patient? You can see now the stage A, which is it's important to know the stages actually, but I'm just going to concentrate on stage A, because if you have a patient who's diabetic, that means by default, by time, he will become a cardiac patient. So to prevent this from happening, you have to make sure that you are giving your patient the proper medication. You can see now that diabetes has about the highest percentage after hypertension as a risk factor in cardiac patients. One of the issues of the heart failure patients is that they have a defect in the compliance of the diet and the therapy. Exactly the same problem in diabetic patient. Imagine if you have a patient that has 2 problems and not adhering to the diet or not even to the treatment. So you have to give it an aggressive way of treating the patient. Now this is just actually just a brainstorming, so we can just refresh our information about both issues. The problem when you have a diabetes and that will induce the cardiomyopathy, this is where you are really facing a challenge, and it's very difficult to win this challenge. So what about the management of diabetes? In general, when you're talking about managing diabetes, that means you need to go to a goal, to a target, where your hemoglobin A1C in the patient has to be within a range. Usually, if you have a heart failure patient, your range is supposed to be 6.5 up to 7, but not more than that. I do believe in our clinic, sometimes we even see like 11, 12, even 17. And this is not acceptable, especially in cardiac patients. This is the diagram of the treatment of diabetic patient. Again, this diagram is a big diagram. It's the actually summary of the guideline, the new guideline of diabetes. I'm gonna just like talk a little about some of the diagram. This is approved by the American Diabetic Association and the clinical endocrinology. But this does not apply to your heart failure patient, because you have some drugs that are contraindicated in heart failure patient, and some drugs that you prefer to be starting with in those patients. For example, here, as you can see, the A1C, this is the levels that will direct us to the proper way and the proper class to use. If your patient is less than 7.5, so that means you are in the monotherapy range. And the best one to start with is metformin. I'm talking about general diabetic patient or in the process of having diabetes. So the best class is the biguanides. And then comes the least. We'll talk about each one in details. But if you're not able to achieve the goal within 3 months, that means you have to dual the therapy. Metformin is number one with one of the other groups. What about if I waited another 3 months and I did not get my target? I can even go to triple therapy. So usually when you have a diabetic patient, you don't change the dose within next visit unless the visit is 3 months apart. What about if your patient was more than 9? This is the hemoglobin A1C. You have to work hard, because if you have a symptom patient, you have to be very aggressive. And you have to, in this case, don't wait. Go to insulin directly and try to give this frequent regimen insulin. Because your patient now is developing the complications of cardiovascular, fatal and non-fatal. So we just went through that in a summary. There's some drugs of them that are contraindicated in heart failure patient, and we'll talk about it in details. Starting with biguanides. You know, biguanides by nature is a herbal medicine. It started from this flower, and this flower actually was discovered in the Arabic area. So it's an Arabic medication. And then it went to Europe and then to the US. So now it's like everywhere in the world. They use it as a first-line treatment, even in prevention. So again, we need to know that metformin or glibenclamide, actually, biguanides, this is the second generation. The first generation was withdrawn from the market because of the liver toxicity. So this is the second generation, metformin, and it does not cause hypoglycemia. It will just work on the balance between the glucose level in the blood. There was a trial done as a cohort study, and they said that with heart failure patient and diabetes, using metformin, and they followed the patient for 2 years, the hospitalization for those diabetic heart failure patient, and the primary outcome was the time of death within these 2 years. The second outcome was the time of hospitalization in those heart failure patients. You can see here now that with metformin, the result was a little bit better. So even if you don't do anything except just giving your patient metformin, make sure the kidney function is fine, you are saving the patient. Another trial was done also in 1,800 diabetic with heart failure patient. Again, they were given metformin with different doses, and also sulfonylurea with another different doses. The third group was a combination of both. And after following up those patients for 1 year, the hospitalization, they found that the best result when you combine these two agents together, a little bit different when you give it metformin alone. So this will conclude that metformin is the golden star for those patients. If you still need to add a group, you can add the sulfonylureas. What about sulfonylureas? They cause hypoglycemia, and they have to be given with caution. These drugs actually, we always go to the second generation, not the first, not the third generation. Because the third generation is once daily. We try to avoid giving these long-acting drugs because we don't want the patient to go into hypoglycemia. Again, you have to be careful. You have to monitor the patient electrolytes, and of course, it will cause increase in the body weight. So you have to instruct the patient about giving the proper diet when giving this medication. The study said that in retrospective, almost 17,000 diabetic patients with using metformin, and then they compared them with using sulfonylureas and insulin. And they were actually looking for the primary endpoint, which is myocardial infarction, stroke, death. And they tried to compare again the metformin, insulin with sulfonylureas. You can see here now what they did. They actually excluded some of the patients. And then when we went through one by one, which is giving them metformin, sulfonylureas, sulfonylureas and insulin, they compared all the group together and they looked at the cardiovascular events. You can see now, according to the p-value, that the difference wasn't much, which means either you give metformin or sulfonylureas with insulin, you are still in the right range. I will give you the summary of everything, but I'm just trying to go with you just slightly with some of the studies, so it will be an evidence-based information. The third group is the thiazole group, and you know, the famous one that was withdrawn from the market, which is the rosiglitazone, and it was after the DREAM study because of the cardiac toxicity. Because of that, it's a mandatory now for each diabetic drug to give a safety profile for the cardiac organ. That's a mandatory now. So they do not release any diabetic unless they have a safety profile before they use it on the cardiac patients. The RECORD trial tell us that with diabetic patients, metformin or sulfonylureas, each one alone, and adding on the top of that rosiglitazone, the point here is that they want to see the cardiovascular hospitalization and cardiovascular death. So we have a group of metformin, a group of sulfonylureas, and rosiglitazone was added to each one of them. You can see now the result here, that the number of deaths was more for the heart failure death. It was more, which means now the difference here between the last trial and this trial was the rosiglitazone. That means this group should not be given for cardiac patient. Now I'm talking about rosiglitazone. Does that apply to actose? We will see that in the next trial. Again, there was another meta-analysis that talked about 16,000 patients. These patients were followed for almost 3.5 years. Again, this study was with actose, and it talked about the ischemic cardiovascular events. Again, the primary endpoint was death, myocardial infarction, and stroke. The secondary outcome was measuring the serious heart failure issues with these patients. You can see now, bioglitazone had a better effect than rosiglitazone. But again, this is not a choice to start with in a cardiac patient. Try to avoid it as much as possible. Dipeptidase inhibitor, it's a new group. It's not that new now because there is something even more newer coming up. And this drug actually, again, works on the incretin, and it just actually works on that enzyme. You know, incretin, even it helps in digestion of food and even releasing the glucose to a simple form to go inside the cell. So these drugs are specified for this kind of mechanism of action. What happens is that in these drugs, there's something which is a big side effect, the peripheral edema. So should we use it or not? We will answer this in the end of the presentation. And again, you have to be careful. It causes hypoglycemia because the patient will feel hungry sometimes, and sometimes they might go into DKA. So you have to be very careful. In the primary endpoint, when they said, for example, sitagliptin, they did this famous study, and they found that It is comparable to placebo, so the side effects of that drug on the heart is not as we thought it's toxic. So you can see now this is the fourth group, and this is the results of the studies. I know it's a little bit confusing, but don't worry, we're going to summarize it in the end of the presentation. Glucagon-like, again, they are a new group, and they are used, and they will work on the hypoglycemia. It causes hypoglycemia. It has side effects. One of them is very severe headache sometimes when you start with it, but you have to keep it with caution and with monitor. The trial was done on almost 300 high-risk patients to reduce the with low ejection fraction in order to see the primary endpoint, which is the death because of heart failure and hospitalization. And the indicator was the proBNP to measure is the patient improving or not. According to this study, they said it will improve. So that means if I'm going to use this drug, I will give it, but I have to monitor the patient proBNP and also the hypoglycemia issue. Sodium glucose transport, which is another group, and this group actually works on the tubules. It will decrease the reabsorption of glucose from the urine, so it will just be depleted outside. If the patient has any renal issues, you have to be careful. Its most famous side effects is the urinary tract infection. The study was done on almost 7,000 patients, and those patients were monitored up to almost 3 years. The primary endpoint was the death of cardiovascular problems, and they found that there is a difference between placebo and this drug. So that group could be another choice for me if I'm going to treat a heart failure patient. The golden drug that will never just be deleted from any formulary is the insulin. Regardless what type of insulin we're talking about, insulin is the solution, but I think now we can work on the dosage form. It has a side effects. One of its side effects is the hypoglycemia and the weight gain, and there's no solution for that. So you just have to monitor your patient. A lot of studies have been done on insulin, and they said that with even a long monitor of your patient, you are saving the beta cells, you are decreasing the complications and the cardiovascular complication of these patients. So you can see now when I'm using the insulin, it's the golden star, but you have to also know which type of insulin you should use. Glargine actually did not make any change. So it's not the fancy of insulin that you're using, no, it's the regimen of insulin. So you might use like the Rispro, which is the short acting, but frequent injection is your target. Another trial was done on 2,000 plus patients, again, monitoring the MI and the cardiac problems. And they were followed for almost about from 2 to 5 years. And they were following the morbidity and mortality for those patients. And again, they found that in the endpoint that the cardiovascular mortality did not change when you compare it with patients with insulin and without insulin. I know the time is becoming limited, but so what should I do with my diabetic patients? I think you should follow this summary to make your life easy. Just print it and put it in front of your desk in the clinic. In our clinic, Dr. Walid usually used to tell me, Fakhr, diabetic patients, just transfer them to endocrine. I tell him sometimes, let us try, give it just a trial with the patient, because they just need monitor and they just need education and the proper medication. I do believe that insulin is the golden star. Even endocrinologists, to be honest with you, when we go and we start treating the patient, the old school used to tell us, try the monotherapy, the oral, and then another monotherapy, oral, then the end stage would be insulin. It's not the practice anymore. Endocrinologists now would really like to start with insulin, even if the patient is still newly diagnosed, because you need to save the beta cells as much as you can, and instead of waiting for it to be distracted totally and giving a very high doses of insulin. So again, you can see now, insulin is number one, metformin. It will even decrease the cause of mortality. Sulfonylurease is another option. Avoid as much as you can the thiazide, the TZD group. The dipeptide are a natural effect of the neutral effect on the cardiac outcome, and the glucose, the glucagon-like.
2 more minutes.
Yeah. Just 2 more minutes, okay? Glucagon-like peptide also, these studies tell us it has a negative effect on the cardiovascular outcome. The sodium glucagon, a study shows that it's a promising effect on the cardiovascular outcome. There's still one study that will be released in this year for, again, comparing those drugs and those groups. So to summarize it for you, I think insulin, metformin, sulfonylurease. Sometimes we can add the sitagliptin if your patient needs it and if he's in the right stage. There's another injection that is now taking place, which is called Victoza. Again, this is not now, this is for the protection when you have an impaired glucose tolerance, but not when you have a diabetic patient. I think we have to keep it bumping, as we always say. And thank you very much.
Thank you.